Dr. Mark Yackley is an internal medicine physician who's been with the Hutchinson Clinic since 2006. He's board certified by the American Board of Internal Medicine and graduated from Creighton University School of Medicine in Omaha. He did his residency at the Medical College of Wisconsin. We're going to talk to Dr. Yackley about an area he's developed an expertise in, and that's hospice and palliative care. Welcome to Doc Talk, Dr. Yackley.
Thank you, Dr. Crater. Good to be here.
Well, good to have you here. Dr. Yackley is my call partner in internal medicine. He and I have been practicing together for 10 years.
Can't believe it's been 10 years. It's gone by very quickly.
Yeah, you have a huge internal medicine practice. Dr. Yackley is a very popular physician in Hutchinson, and it's been a pleasure to work with him for 10 years. So you've developed a broad spectrum internal medicine practice, but have also developed a real interest and a heart for people who are suffering and dying. And that's a special area of medicine that not everybody is cut out to serve in, Mark. So tell us a little bit about what hospice and palliative medicine is.
Those are two terms that a lot of people get confused, and sometimes they may think they're very similar. They are similar, and yet they're different. Hospice care basically involves potentially the last 6 months of a person's life when they know that, and their treating physicians know that there's not much more that can be done medically, and it's at that time where we look to treat people on a comfort care mode rather than trying to be real aggressive and trying to treat their or cure their medical illnesses. We know at that point it is futile, and that we look to relieve their pain and suffering and help their last remaining days, weeks, months to be more comfortable and hopefully pain-free. Palliative care is also very similar to hospice. However, a person can have palliative care and still seek active treatment, whether it be for cancer, Alzheimer's, COPD, heart disease, or many other illnesses. Palliative care brings in a whole team, not just nurses and doctors, but also social workers and other professionals to help as kind of a second blanket, if you will, for your doctor and other treating members of your team. Palliative care is not going to be taking the place of your primary care physician, but think of it as we're an extension of your primary care doctor. When they can't be with you in the home, our services can be there. We can help provide means to help with a lot of the symptoms, such as nausea, additional pain control, and overall just helping people feel better and have a better quality of life.
So it's kind of a spectrum of treatment. Hospice and palliative care, you're board certified in them, and it's kind of a unified board. Is that correct?
Yes, it is. There is up until about 2013, there really wasn't a recognized board of palliative care and hospice. There was, but you had to actually go and do another year of beyond residency in order to practice hospice and palliative care. It was a very young field, not very attractive to many people. So it didn't bring in too much interest for many physicians. Now, with the growing aging population of our society, they have realized that we need more and more physicians in hospice and palliative care. They actually opened up a new board certification where you can become a certified hospice medical director after passing some tests and certainly doing a certain number of hours of work in hospice care. Otherwise, you would have to, quit your practice and go into a traditional residency program for a year to do a fellowship, and then come back and practice, palliative care and hospice. Well, in today's world, that's impractical for a lot of physicians. Yeah. So thank goodness the board did come up with this new certification for hospice medical directors, where they do not have to take a year out of their practice, but yet they can still be involved in their field, become board certified, and be able to lend a very crucial expertise that is needed in this growing community and society.
Yeah, I think it's wonderful that we have you in the community that is a person who is specially trained in such an important aspect of the practice of medicine. We see medicine as a growing hyper-technical field where we have all these high-tech interventions and all of these things that can be done to patients. And I like to differentiate what can be done to someone versus what can be done for someone. And sometimes they're two very distinct things. I know we've talked about this before, Mark. You can do a lot of things to somebody, and you can do things for them, and sometimes the twain shall never meet. We do a lot of things to intervene on an organ system, and sometimes it doesn't do a darn thing for the person. I think in hospice and palliative care, everything you do is for that person. It's for their dignity. It's for the relief of pain. It's for the family. It's for helping them get to a satisfying end of their life. And so I think it's such a privilege and an honor to have somebody like you in the community who is specially trained to facilitate the end of life, because you and I have both seen people who had a good end of life and people who had a horrible end of life. And a lot of times it kind of revolved around whether they chose that hyper-technical ending, that souped up, I'm going to do everything I can to have an intervention, versus the death with dignity pathway, or the pathway that involved, having peace. And to me, there's sometimes two very different pathways. What do you think about that?
There are two different pathways. If we, stop and think, how much money is spent on a person's life at the last year of their existence. It's staggering to think over $1 million is spent in extending somebody's life. And how much are we extending it by? A week? A month? And what is that quality? Yes, we live in a great world. We have a lot of medical interventions. We're at the pinnacle of many societies and what we can do for people. But unfortunately, we are also, part of a bigger world. And there's a creator out there who's in charge of all of us. And unfortunately, we are all mortal men and women, and we are going to die someday. And we have to learn, not only is it good to live well, but we also have to learn how to die well. And that's a very hard concept to understand. Nobody wants to die. I certainly don't want to die, but I know that's going to happen because I'm a mortal man. And I just hope that what we do here on earth will help us get to heaven someday. But we do have to look at our life and how can we end it in a very peaceful manner without having a lot of things done to us. If you interview many people probably 90% or more would rather die at home than in a hospital. Unfortunately, what happens? Those statistics are reversed. Many people die in a cold hospital bed and not having many family members around, versus where they would rather die is at home with many family members around and more peaceful. Doing a lot of interventions that can be painful and not really extending a person's life are not what we are about. However, it's a hard concept to try to get out of, because many physicians, if not all physicians, we come into this practice, we want to save lives. We want to help people feel better. We don't want to, back away and show people that we don't care. But we do have to come to realize that, yes, we all are going to die someday, and we need to take a better look at the end of life care, and how can we make this better for our patients? How can we make this less intrusive and less painful?
I think that's a great point. I think we'll pick up there right after this. I'm back with Dr. Mark Yackley talking about hospice. And before the break, we were talking about the philosophy of hospice care and how we do things sometimes for people, and how sometimes we fall into the trap in the practice of medicine of doing things to people. And really what we want to do is preserve people's dignity and do the right thing for them. What I want to do now is just talk a little bit more about Dr. Yackley, the person, and his family. Mark, what brought you to Hutchinson, and how did you get involved in the Hutchinson Clinic? How did you wind up here?
Well, I actually did my medical school and undergraduate work at Creighton University in Omaha, Nebraska, and then ventured up to Milwaukee, Wisconsin at the Medical College of Wisconsin for 3 years, doing my internship and residency there. I practiced in Appleton, Wisconsin for 13 years before becoming subjected to a practice that was bought out by a HMO who made a lot of promises that actually were not realized, and I became very frustrated with my practice. And at the same time, I had a partner who went into hospital medicine, and a second partner who unfortunately came down with cancer and was had subsequently died within a year's time. So it really, I guess, rocked my world, and I wanted to find a practice very similar to what I had been in, and it led me to Kansas. My wife was saying, "Kansas? Are you nuts?"
She's from Wisconsin, is that right?
She is from Wisconsin, and I'm originally from South Dakota, which 2 states above Kansas isn't too much different. The wind always blows, just in a different direction.
A little cooler up there.
Little cooler.
And you have 3 children.
I have 3 children. Stephen is my oldest. He's 21 in college. He's a junior at Creighton University. And I have Hannah. She's a freshman. She's 19. She's also at Creighton University, both studying pre-medicine. I'm excited about that. I've never encouraged or discouraged them, so we'll see where that goes. And my third child is Tessa. She's a sophomore at Trinity High School here in Hutchinson. Don't know what Tessa's going to do, but whatever she does, I know she's going to go far.
And your wife's an attorney, is that right?
Yes, she is. Laura, my wife, is an attorney. She did practice for a couple years up in Appleton, Wisconsin. And after we had Stephen, she decided to stay home. She did a lot of law work and family law, and she represented a lot of children in custody battles and other nasty situations. And she realized, look, I want to stay home and make sure our children have the best education possible and best life. And luckily, we were able to do that.
That's great. You've raised a wonderful family. You're a family of service oriented. Your father was a doctor. You're a doctor, and there's going to be, I think, there's going to be at least one more doctor, and maybe two coming along here. So that's wonderful, a wonderful family. Tell me a little bit about your hospice work. You work for Hospice of Reno County. Is that right? You're the medical director. Is that correct?
I am. I'm the medical director. I first started hospice in 2007 after I came here. What kind of intrigued me was when I was up in Appleton, Wisconsin, I had a number of patients that I feel I'm always close to my patients. I like to follow them even, at the very end. And some of them went on hospice, and I was not able to follow them. That really irked me. And so I called the medical director up there and said, why? Why can't I follow them? Well, because they're on hospice. It's like, okay, what's so special that you do that I don't do? And he really couldn't tell me an answer. And when I came down here and this opportunity opened up that I could be involved in hospice, I decided to try it, and I loved it. I knew that there's a lot of physicians aren't real comfortable with people dying, and I knew that there's a lot of people out there that do need some help. They need comfort. They want somebody around who's willing to be with them. Maybe it's only for last remaining week or day or even hours of their life. If I could make their life a little more comfortable, enjoyable, pain-free, or relatively pain-free, then I feel maybe I've done some good for them. So I looked at it as maybe this is my way I can contribute to the community and give something good back to them that they've given to me.
Well, I think that you do, Mark. And in a lot of ways, what you do is like a priesthood. And I know that you are a good Catholic. And what you do is like a ministry. And there is no doubt about that. You are known for your compassion in this community. And I think that's one of the reasons why you have a massive internal medicine practice, is that people recognize that about you and that you're the real deal. You're very highly respected. You certainly do meet the people at the point of need, and you're not afraid to be with somebody when they really need help. And I mean that from the bottom of my heart. It's an honor to work with you. And you never stop working until the work is finished. And there are not a lot of guys who are able to do that or willing to do it. The palliative care service is a new thing that you guys have rolled out. Tell me a little bit about that.
We actually rolled that out. It will be almost a year ago, mid-April. And that is actually slowly picking up speed. As I mentioned before, it's a secondary or extra layer of support for the person's primary care provider and other people involved with their care, that we can help palliate their symptoms. Maybe their primary care physician might not always be available, but our nurses, social workers, chaplains can be available to help with some of the more intricate details, such as psychological and spiritual needs that a person may have. And that has really picked up speed here in the community, and also, more importantly, throughout the whole country. This is just not localized in Kansas or Hutchinson. This is a very, very popular and growing need throughout the country. as I may have mentioned before, 20 years ago, you probably never even heard of palliative care, let alone hospice. But both have certainly grown into entities that are very well known and sought after, especially by many people who may have unfortunate terminal illnesses or diseases that are very chronic and are not going to get better. One important distinction, again, to note is palliative care doesn't necessarily represent hospice. That's where many people turn away from and think, uh-oh, my doctor's giving up on me, my team's giving up on me. That is not the case. We are here to help you. You can still receive active treatment. You can still receive chemotherapy and other interventions while on palliative care, which is different than hospice. When a person enters into the realm of hospice, that's when we realize, we being medical team, realize that there isn't anything more that we can actually do to get this person better, that they do need something different. And this is where, they need more, compassion. They need more time spent treating their pain. We know that they're not going to get better. And we know with being on hospice, they usually have 6 months or less of life expectancy versus palliative care, where that life expectancy can be certainly innumerable. It doesn't necessarily mean it's 6 months or less. It could be several years. It could be several decades.
So it's the palliative care team can come up alongside the active treatment team and work in tandem with them, as opposed to the hospice team, which is really kind of the team that takes over from the active care team and says, okay, we're going to focus on symptoms, and that's really going to be the main focus. But the palliative care team can come in and you can still keep your main focus on your treatment. Is that right?
That is correct.
Okay.
That is correct.
But the palliative care team brings a little bit more expertise so that you're not suffering while you're getting your care. There are a lot of times when I'll be at a loss as to exactly how to treat someone's dominant symptom. I could ask the palliative care team to come in and help me with that.
Exactly.
Okay.
Exactly. And we're not taking over the care of your patients.
Right.
We're helping you care for your patient.
I think that's perfect. I've done that too. I've consulted you a couple of times when I thought, when I was in a pinch and didn't really know exactly which way to go. It's nice to have a team come in, when I'm stretched thin, and have you guys focus in on some particular aspect of the patient's care that I just can't seem to get my hands around. No man is an island. No guy has a monopoly on knowledge, especially not in medicine, not these days. So it's great to have doctors like you and teams like the one you head up be able to come in and offer your expertise, especially when the patient is suffering. I think that's really great. So, Mark, it's been great to talk to you today. It's always a privilege to speak with you about things. You have such conviction, and it is definitely true that still waters run deep. You're not a guy who is giggly and a bubbly guy, but you're definitely a guy who has a lot of depth, and I really appreciate having you here. Thank you for coming today.
Well, thank you, Tim. I appreciate it.